Recording now. So welcome everyone to the Civics Project. I am Beth Ribet, the Director of Repair and the host of the Civics Project, and I'd like to begin with a land acknowledgement. Repair acknowledges the Gabrielina Tongva peoples as the traditional land caretakers of Tobangar, the Los Angeles Basin, and South Channel Islands, and we're grateful to have the opportunity to work for the Tarakatom, the indigenous peoples in this place. We pay our respects to Hanukvatam, the ancestors, Ahihiram, the elders, and Eohinkem, our relatives and relations, past, present, and emerging. Our session today focuses on Medicare and Medicaid in the United States. And I want to begin with just a little bit of history. Medicare and Medicaid are basically 55-year-old systems in the United States. They were founded under the Lyndon B. Johnson administration in July of 1965. So this summer they'll turn 56. Although Lyndon B. Johnson was at the helm of the executive branch of the United States when these systems were created, the call for a national health insurance program did not start in that time period. There was earlier advocacy in different times and a more explicit call for a national health insurance program from the executive branch of the United States government beginning in 1945 when President Harry S. Truman indicated that it was something needed in the United States. And as you can imagine, there was a fair amount of discussion and struggle about how significantly the United States might invest in healthcare for its people. So what emerged were Medicare and Medicaid, which were programs exclusive to only portions of the US population. So I'm going to talk a little bit about each program and the way that it has functioned and does function today. And I'll start with Medicare. So as many of you may know, Medicare is exclusive to people over 65, and it includes hospital-only coverage, often known as Medicare Part A. So basically coverage just for when you're hospitalized, but it also has more standard medical insurance for routine care, including doctor's visits and equipment. And that's covered under what's known as Medicare Part B. And these were the original components of Medicare, but over time, the Medicare program has developed. So there's now something called Medicare Advantage, also known as Medicare Part C, which includes the hospital coverage of Part A, the routine healthcare coverage of Part B, and some additional options such as vision and dental and prescription coverage. And then there's Medicare Part D, which has been added to create more expansive prescription coverage. And there's a program called Medigap, which has been added to cover some of the costs that otherwise would be passed on to users. And not everybody gets the same coverage, and they're not all free for everybody, and the system has grown quite complex and dense over the years. So I won't try to unpack it completely other than acknowledging that fact. But what I will say to qualify is that Medicare doesn't necessarily cover all medical costs for a given individual. There are co-pays and co-insurance for most users. And many Medicare programs do have premiums, some monthly payments that an individual needs to pay in order to maintain the coverage, for instance, to Medicare Advantage or Medicare Part D, or Medicare Part B, which is the routine health insurance. So a common misconception is people think that you turn 65 and then all of your healthcare costs is covered, everything is taken care of, and that's not actually the case. Medicare basically functions something like private health insurance programs do, that you can buy into it and that it pays portions of your medical costs, and it covers some kinds of costs and not others, and some portions of those costs. But what differentiates Medicare from private health insurance is that Medicare programs are publicly funded. So you may have noticed if you paid a paycheck in the United States that you'll see Medicare withholding. and the money that's taken out of your paycheck goes into a fund and helps create credits for you, which support your Medicare access later on. So Medicare, as noted, doesn't necessarily cover everything. It is publicly funded. And a key reason that Medicare exists is to ensure that as senior citizens retire, they won't lose access to health care. So in some significant part, the fact that Medicare is structured in the way it is a reaction to the fact that we have attached healthcare in the United States for most people to, or for most working adults at least, to employment. So you get access to health insurance through an employer, and therefore Medicare picks up at the age of 65, so that if you retire at 65 and you're eligible for other programs like Social Security, it won't mean losing your employer provided health insurance. So this is the basic rationale. Now today, the number of people who are currently Medicare beneficiaries is over 60 million. So this is closing on a bit less than 20% of the US population. And we would expect that that percentage and the number are going to be increasing for the reason that the baby boom generation is retiring. So as we see one of the largest age cohorts, groups of people based on when they were born, passes the age of 65, we'll see an increasing number of people becoming eligible for Medicare. So I want to move next to basic discussion of Medicaid. Medicaid plans serve populations under the age of 65, as well as serving some seniors, and are based in large part on economic need. Eligibility for Medicaid is quite complex, which you know if you've ever needed to apply for it, or tried to assist, or just been bearing witness as somebody else was going through the process of Medicaid qualification. There are certain groups which are considered eligible nationwide, so regardless of whether you live, you can qualify for Medicaid. But there are also differences in states. So there's a basic federal set of groups that are considered eligible anywhere in the nation. And then individual states can choose to expand Medicaid access to particular populations. So an example of this is that some states have taken some steps to make sure that children in foster care start receiving access to Medicaid as needed, but not every state has done this because there's no guarantee for foster children at the federal level for Medicaid access. So again, it's state by state, and there are a number of different ways in which states can structure the economic threshold and other sorts of thresholds to go beyond or to stay at that sort of federal bare minimum of who's covered. Medicaid is funded jointly by federal and state governments, which is one of the reasons that states have some discretion about how expansive they want the plan to be. And it's the largest source of health coverage in the United States. It currently reaches 72 million people, and that makes up more than 20% of the US population. Medicaid eligibility was expanded under the Obama presidential administration, specifically via the Affordable Care Act of 2010, often referred to as Obamacare. States still have significant discretion in when to enable Medicaid coverage for low-income adults, but the Affordable Care Act did expand options for states that choose to voluntarily give more coverage to low-income adults. In other words, the federal government agreed to help fund expanded Medicaid standards if states chose to do that in their states. One question that comes up for people is, can you have both? Can you have Medicare and Medicaid? And yes, if you're a senior who qualifies economically, you can have Medicare and Medicaid, both. And the reason people combine them is mostly to have Medicaid cover costs that Medicare recipients would otherwise have to pay out of pocket. So I want to talk about some of the problems and challenges associated with these two systems. And I want to highlight, this is a major cost in the United States to the federal budget. So the estimates and predictions of what it will amount to vary, but at looking at any given statistics, I'm usually seeing, whether it's a current statistic or projection, numbers indicating that Medicare and Medicaid are accounting for anywhere between 15 to 20% of all the money that's spent out of federal tax dollars in the United States. They're considered, and some estimates are larger, so they're considered, again, an enormous part of the US federal economy in terms of the money that the United States government administers. And we shouldn't underestimate how much that will be true in the coming years, because the number of people who need and qualify for healthcare based on economic need is increasing in our pre and pandemic, and will be also at issue in our post-pandemic economy. In other words, we're not doing well in the United States. A lot of people are poor and don't have sufficient access to healthcare other ways, and so the need for Medicaid is very high. The need for Medicare is also expanding, again, because the baby boom generation is retiring. So both programs are seeing increased demand. So I want to say that for context, and then as noted, I'm going to talk through basically 7 areas of concern, so major problems and challenges that advocates and policymakers are currently thinking about relative to Medicare and Medicaid. I want to emphasize that these are not exhaustive. These are not the only problems that exist, just the ones that I'm going to cover in limited time. The one problem and challenge associated with Medicare and Medicaid are that the out-of-pocket costs, particularly for Medicare users, but also for Medicaid users, because even in instances where Medicaid is supposed to be fully covering a healthcare cost, it may be that what a person needs is not considered Medicaid eligible, and so people still wind up either not getting or having to pay out of pocket while being Medicaid recipients. So one of the challenges is that the estimates for what an individual should have to pay as a copayment, a premium, or out of pocket often don't take in the realistic cost of living in particular areas of the country for elders with disabilities. So there are lots of costs that come with becoming increasingly disabled. And often the amount of available or disposable income that the federal or state government is imagining that an elder could put into their health care isn't a realistic estimate if they need, if they're of their need, if they're having to pay for other costs like having someone else transport them places and needing in-home help for things like housekeeping. So again, the cost of living is not always realistic either to the standard of living in the part of the country at issue, or to the realistic costs that people who are dealing with health and disability issues are having to cover, which are not covered by insurance programs of any kind. The consequence is that federal and state policymakers will say, okay, a person at this income level can afford to pay this when they can. And when we see that happen, sometimes what will be true is that a Medicare beneficiary will complete, let's say, part of the treatment that they need for a particular condition, but maybe not be able to afford a particular prescription. And so therefore the treatment is less effective because the costs of their health care exceed what they can cover. And as you can imagine, when treatment is incomplete or there's some treatments people are not receiving, this can have all sorts of medical consequences, in the worst cases, including death in an immediate sense, or based on reduced life expectancy, people dying sooner than they would, even if it's not as immediate. So the failure to recognize the real costs of living and to consider those costs from the perspective of an elder or person with a disability is one of the problems. The second is the accessibility of the care people need. So there is no federal or state mandate that says every licensed healthcare provider who's doing business as such has to take both plans across the board for everybody. Healthcare providers can choose not to except, for instance, Medicaid recipients. And the consequence is that this reduces the networks and providers that people are able to go to. So let's say someone becomes a Medicaid recipient after losing a job and employer-provided health care. They may find that the health insurance or the health care providers they were able to see before are no longer covered once they become a Medicaid recipient. So this can create disruptions in care, fewer options. The option that Medicaid will cover may not be the person that you need to see, especially if you're in an area that has a limited number of people practicing in a specific specialty. So care can become less accessible. Sometimes the Medicare and Medicaid, the Medicaid, particularly receiving providers, may not be geographically accessible to you. So there may be a bunch of healthcare resources that are close enough to you, but they don't take Medicaid, and the one that you can get to may be a town over, maybe 30 miles away, may not be accessible to bus lines, right? So the fact that there are limitations on where you can use publicly funded healthcare is one major challenge. A third area is denial of treatment and gaps in treatment. So sometimes Medicare and Medicaid do not cover things that might be available privately if you paid out of pocket, or might be available if you had private health insurance, such as Blue Cross or Aetna or even Kaiser. And one thing to understand about that context is that when you've got, let's say, a health insurance carrier like Blue Cross, for their own profit margin, because they are a for-profit company, they're going to be wanting to reduce what they cover and to often place more restrictions on what they recognize as medically necessary treatment. But they're getting some pushback, not just from consumers, but often from providers. So a doctor who wants to provide a patient with a particular treatment, if the insurance company provides that care, or doesn't want to provide that care, the doctor and the patient can work together to appeal to try to get the treatment covered. In theory, that can happen with Medicare and Medicaid as well, but in practice, it's very difficult to do. So Medicare and Medicaid also, the federal and state governments also may have a profit motive, or not a profit motive, but a cost motive to keep costs down. But they may be particularly resistant to making any change, particularly since it's going to affect so many people across the board. So often without that same pressure from providers who are used to contesting denials from companies like Blue Cross or Aetna, Medicare, Medicaid provision may be less expansive. And that contributes to the fact that some providers will then just avoid taking Medicaid, for instance, because they do not want to have to deal with the limits on what kinds of care is covered, as well as with limited amounts that the US government or the state will pay. A fourth problem with Medicare and Medicaid systems is that the systems are complicated. They're not user-friendly necessarily, either from the perspective of healthcare providers who are trying to get their insurance bills paid, or from the perspectives of consumers, recipients of care, who are trying to use these systems to get their needs met. The process of qualifying, the process of filing claims, the process of appealing, the process by which benefits are increased or reduced, all of this happens in ways that usually members of the public can't follow. Now, it's an argument, are Medicare and Medicaid any worse in this respect than private insurance companies? And in some instances, I would say no, they're not necessarily worse, but they're as bad. And in some instances, because we're dealing with the interplay between eligibility and federal and state government, and there's not the natural pathway through an employer, the process of qualifying for Medicare or Medicaid, or of filing a claim, or of appealing a decision, or even of just figuring out what it is that you're eligible for, can in fact become harder comparatively relative to most private insurance systems. So complex systems, which again can delay care, result in inappropriate denials of care or disrupt payment. And that brings me to the fifth issue. Medicare and Medicaid systems can be slow, and that can result in delayed payments coming to healthcare providers for the services they provide, which then can disrupt treatment or create challenges for consumers. It can be that sometimes while payments are getting held up, providers will try to bill consumers directly, although there are some restrictions about when they're allowed to do that. And it sometimes is true that providers will disrupt care while they're waiting to be paid for prior delivery of care. So delays in payments, the fact that the systems are not particularly efficient or fast, is a fifth problem, although I will say this is not unique to Medicare and Medicaid. It happens with private insurance plans as well. Inadequate payments, with a corresponding problem of limitations on access to providers, which we discussed earlier, is a sixth area of concern. So the caps on what Medicare and Medicaid are willing to cover for a given session, treatment, or resource tend to be quite tight, and usually they're considered the lowest, and so they may be followed or copied by private insurance carriers. So in other words, regardless of what's generally being offered to the public, what Medicare or Medicaid will pay back to a provider for a service is capped. And if they are accepting those programs, then there's only so much that they are allowed to bill. This creates a number of challenges. In some instances, what it does is incentivize providers to cut treatment or service times short. So for instance, if you can only get $30 for each visit with each patient to meet your costs, to pay your office staff, your malpractice insurance, maintain your license, pay for office space, pay for cleaning services, for everything else that goes in to maintaining a healthcare facility. If you are getting $30 per clinician per visit, often that results in providers saying, okay, well then if we're getting $30 per visit, to make enough money, we need providers to see a minimum of 4 patients per hour. And that creates a lot of pressure because patients coming into the doctor's office with complex healthcare problems cannot always resolve those, have those conversations or get fully examined or discuss treatment options in 12 minutes, 10 minutes, 15 minutes. And it also doesn't allow providers enough immediate time to take notes, to transition, to do all the things that they need to do between patients. So if you've been in a physician's office, whether you have private or public insurance, and you're noticing that it just feels like they walk in the door and they're already halfway out the door. A lot of times what they're responding to is that structural pressure, whether it's from Medicare or Medicaid, or from a private insurance system, that they know that there's only a little bit of money that they're going to get for seeing you. And if they want to meet their own bottom line, then they've got to move on to the next patient quickly. As you can imagine, these kinds of deficits in care, not having enough time, can result in misdiagnoses, inadequate time for patient decision-making, which then may mean that patients won't wind up doing what they need to in order to care for themselves in between visits or treatments. It can result in patients not having time to ask questions. It can create more tension or a lack of rapport between patients and providers, because when, regardless of the structural reasons, when you feel like your healthcare provider is not listening to you or doesn't have time for you, it doesn't build trust. And there are a number of reasons why trust between patients and healthcare providers can affect medical outcomes. We have a significant social, scientific, and public health literature that tells us that the relationships matter. So having that profit or bottom line motive motivate healthcare providers not to spend time with their patients is a major consequence. But there's some others. One is that if there are caps that limit the opportunity for profit on a particular kind of treatment. Doctors are less likely to want to use that treatment because it's not making them money, and that may result in them not recommending it to a patient. If there are limitations, for instance, this is a common one, if an insurance carrier, whether it's public or private, puts the limitations on the number of days of a hospital stay that it will cover, and hospitals are not allowed to release people before they are ready to go home, that may cause them to rush and declare that they're ready for release sooner than is safe, so that they can clear the bed, right? So that they can get someone else who Medicare or Medicaid or an insurance program will pay for into that bed. So kind of rushing care is a second problem. Limiting treatments, limiting time. So those inadequate payments are really significant, and as noted, they also just result in providers refusing in some instances to take programs like Medicaid out of the concern that they just won't be able to make enough money to meet their own costs. The seventh and last major problem and challenge I want to identify today is fraud. So I'm going to just identify a few common types. I'm not saying these are constant, but some of the types of fraud that we do see come up. One is called upcoding, and this is when providers defraud Medicare or Medicaid by claiming to have delivered a more expensive form of care or treatment than they did, right? So to make more money out of the program. And without significant oversight, which can be hard to do with these very large scale programs, think about 72 million people benefiting from Medicaid, often those problems won't be caught, particularly if federal and state policymakers just are not investing the oversight resources that a private insurance company will. So this allows carriers to get more money out of these systems, but ultimately decreases the funding that's available for consumers. And we've got a bind here because sometimes I think providers who are engaging in this form of fraud, upcoding, which again means claiming to have delivered a more expensive form of treatment than the one which you actually did provide, are trying to meet their own bottom line. So part of the problem with sort of underpaying for Medicaid costs is that providers will start to cheat the system in order to try to make it work, but then some will also cheat the system for their own profit. So I feel like solving at least some of the problems for fraud also means the system has to be better funded. People have to be able to make it work. Second form of fraud is what's called unbundling. And this is where a Medicare or Medicaid provider goes into a space like a nursing home or other care facilities to treat one or two people who they were called for, and then submits claims as if they had treated all or most of the residents of that facility. So billing to the system for people you didn't actually treat. So unbundling when you, I'm sorry, wrong term. That's actually group charges. Unbundling, and forgive my terminology error, refers to when you take a clustered group of services. So an example would be, let's say that your doctor said, okay, you need to do some blood work, and they send you in for 3 different blood tests for which they draw one vial of blood. Unbundling is when the doctor or lab which took the blood treats these as 3 completely different costs. So they charge for 3 blood draws, even though they only took your blood once. And so unbundling means taking services which were delivered it all at once and treating each one as a separate visit. So again, this is another form of Medicare, Medicaid fraud. Group charges, as I mentioned, going into a nursing home or other facility and billing to multiple Medicare or Medicaid accounts rather than to just those you treated. And then we also see fraud by insurance brokers who will sometimes try to misrepresent or trick people into signing up for different plans than they were actually choosing, because the brokers get paid a commission anytime that they sign people up. So we'll see brokers try to get people to switch plans so that the broker can make money, basically to make a commission. So, and again, you know, individual instances of some of these things happening are not that significant in terms of the overall cost, but on a national scale, on a state scale, they add up. When you think about 60 million Medicare recipients, 72 million Medicaid recipients, some overlap between those systems, but still upwards of 120 million people, right? That at a systemic level, these forms of fraud also are really significant and not always easy to detect and not always detected. There are a few more things I'd like to just identify during my comments today. One is to talk about the problem of funding Medicare and Medicaid systems. So I've noted twice now, and I'll say it a third time, that as the baby boomers retire, this is becoming a particular crisis. It's not because the boomers have not paid for their Medicare, right? The baby boom aged folks who right now are between the ages of 56 and 74 have been paying into, as a whole, Medicare systems throughout their working lives and have poured a lot of money into the US economy. However, the United States government has mostly spent that money, so most of it has not been held in significant enough reserve to fund these programs. That's not to say that there's none, but that it's not adequate. And as a result, we have a lot of Medicare recipients or future recipients who are headed into retirement or have retired, expect to receive Medicare, have paid into the systems over the years, but now are facing the reality that the United States government has not held in reserve enough money, enough in trust to cover what they've been owed. So there are a few different ways that policymakers have proposed to handle or address this. Some want to reduce the benefits. So the consequence of that would be that people get less health care through programs like Medicare. Others are basically saying, well, we're just going to have to pay it, and we'll be taking it out of paycheck withholding for Medicare for people who are working after. But this basically means kind of running a perpetual debt in an economy that's already got a severe federal deficit in the trillions of dollars. So it basically means that younger working people are paying out of their paychecks to fund people who are receiving Medicare now. And then those tax dollars isn't available for other things that could benefit the general public. So deficit spending by the US government has created a real crisis about how to continue to fund Medicare. And threats to and reductions in service in Medicaid are kind of an area of continual struggle. On top of that, we want to think about this in terms of post-pandemic economic recovery. The United States does have a federal deficit higher than we've ever had in US history, and a significant number of people who are traumatized, which is going to affect both the need for future and current health care and abilities to work and to sustain work. So we should assume that in the United States, economic struggle is going to be an area of concern, even, without our existing class inequities, which, are at issue. That just economic recovery in this present moment is going to be something that's going to be at issue over the coming generation. And then when we factor in structure of our economy, the fact that we have an incredibly increasing and widening gap between the wealthy and poor, and an increasing number of people who are poor, an increasing number of people moving from middle class to lower class to working class. One of the things that we have to grapple with is that people have fewer resources for which to address the deficits in healthcare. So the demand for, the need for functioning healthcare systems is huge. So I want to close today with a few last thoughts before we go to our weekly trivia and book recommendation. And I want to introduce the concept, and some of you may already be familiar, of single payer. So single payer refers to healthcare systems in which there is one central funding source, whether it's a federal government or a state government or something else that takes responsibility for population healthcare. So one way that everything is paid. The United States is clearly not a single payer system. We have a lot of different healthcare payment systems, private insurance companies, public insurance. We have free clinics, right? We have all these different ways in which healthcare is and is not funded. So a single payer system is one in which a government of some kind or a central entity of some kind takes responsibility for the costs of healthcare. And single payer systems can be funded through tax dollars or other ways. It may be that you have to buy into them. It may be that they're covered through taxes, right? So there are different models of single payer systems. The most well-known and most popular currently proposal for a single payer system in the United States is known as Medicare for All. So you may have seen in the last election some politicians running on that slogan. And Medicare for All proposals are as follows. They would keep the existing infrastructure of some parts of the Medicare and Medicaid systems, but Medicare would become accessible to everybody, so no economic threshold to be eligible and no age threshold. Everyone would get health care, universal access. There also would be no premiums and no deductibles under the Medicare plan. So there would be nothing you'd need to pay to get the care, and there would be nothing you'd need to pay before your care kicked in, so no deductible. And in addition, no co-pays, no co-insurance. So when they say single payer with Medicare for All, they mean it. Only the government would pay. Private people wouldn't pay anything towards their covered healthcare costs. So this program would be entirely publicly funded, and it would be essentially universal. There's still areas of debate in terms of how would Medicare for All function relative to people who don't have citizenship. But at least many of the advocacy and indications about it would extend to coverage for residents. And I think the areas you can predict a biggest struggle is what it would mean for people who are not documented in the United States. There's also some questions about how would a publicly funded federal healthcare system interact with indigenous nations within the United States, which are currently under the governance in the United States, but may want to have independent healthcare systems within tribal spaces or for people within their own nation. So still some things to work out, but that's at least the bare bones of what Medicare for All entails. And here are my last thoughts, and I'm going to explicitly say that I advocate for single payer plans. I think that we need one in the United States, whether it's Medicare for All or something else. We should learn, and we need desperately to learn from what's happened during the COVID-19 pandemic. Our 500,000+ death toll so far is in part a reflection of broader ways in which the United States didn't engage in pandemic preparedness and just had unbelievably harmful leadership at both state and federal levels during the time period when it might have been better contained. But my position is also that the number of deaths we've seen is also a reflection of our healthcare system and its deficits. So one of the things that we've seen is that with nations that had significantly lower death tolls, even if initially the spread of COVID-19 looked comparable to what it was in the first month or two in the United States, was that those nations tended to have more beds, more healthcare infrastructure. So compare the United States, in which they were saying, unless you get sick, stay home, don't infect anybody, don't come in for treatment unless you're basically dying or think that you're about to. You can't breathe, or you have, high fever that won't come down, to nations where as soon as there was an indication that someone might be positive, a healthcare provider was sent to their home. And the number of available beds relative to the patient load in a non-pandemic time was something like 5-to-1. So nations where at any given time around 80% of hospital beds might not be filled, meaning that in a pandemic, there was actually room for more people. One of the things that's gone terribly wrong in the United States is that our healthcare systems do not have capacity for any kind of mass crisis. So whether it's a pandemic or something else, when you have too many people sick or injured at once, we don't have the beds, and that's true. because healthcare systems can't profit from empty beds. They can't bill for them to insurance companies. And so in order to maintain their own bottom line, pay their own staff, whether they're a public hospital, non-for-profit hospital, private hospital, right? They still have to cover their costs. And doing so is, in the United States system, is tied to keeping beds filled, filling them as quickly as possible, moving people in and out. And one thing we have not counted in the United States is the death toll of people who have not died from COVID-19, but have died during this pandemic because they could not get health care while the system was flooded or overloaded. So whether the root cause was an injury, heart disease, cancer, diabetes, or anything else that are among our #1 killers in the United States, we've also seen basically an uncounted death toll in the United States. We don't know how high it is at this point, of people who could not get the care they would otherwise have gotten, were not treated in time, and died for other causes in a pandemic context. So one reason that I think we have to move towards single payer is we need a system with more accountability and which is structured to meet the needs of the population. Now, single payer alone wouldn't result in having enough beds, but hospitals which are trying to get paid by multiple insurance carriers are going to want to fill each bed because at least some of them, right, won't give them anything for beds that are empty. So having a centralized system combined with, of course, a commitment on the part of the US state to engage in pandemic preparedness and build healthcare capacity could have, and in future can, prevent the kind of catastrophe and loss of life and grief and trauma that we've seen in the United States in this past year. Single payer also, despite the fact that we do see too much fraud in the Medicare and Medicaid systems, also does offer some opportunities to cut down waste. Also, just to ensure that if there's not a profit motive possessed by, for-profit carriers like Kaiser, as well as secondary insurance carriers like Blue Cross and Aetna, that we will see more of the money that exists for healthcare reaching healthcare recipients. So because insurance companies also have stockholders who want to be making a profit out of the premiums that are collected, right? There's always a chunk of the money that's going into our healthcare system that's not reaching healthcare providers, that's not reaching healthcare recipients. So I would argue that this model doesn't function well in the United States, and that it ultimately means that our healthcare system is far more expensive compared to other first world nations, and nevertheless delivers less. One last reason to note for a single payer model is that we need to move away from employer provided insurance because it restricts people's work options. There are a lot of folks who want to be self-employed. We also have a significant gig economy, so we have a lot of people who meet their needs by working various smaller jobs or by patching together several income sources. And this can create real challenges for folks because if you need to work a certain percentage of time for a single employer in order to qualify for health care, then your options are fewer. And it also incentivizes employers to employ people who want to be employed full-time, less than full-time, in order to avoid liability for providing them benefits. So there are a number of ways in which patching insurance to employment decreases flexibility and sustainability for workers. So we've got some great questions coming in from the audience, and I'll try to just quickly address one or two of them. Dawn is asking, when people have Medicaid, do they lose their Medicare coverage when they turn 65? Not necessarily. In some instances, you're able to keep both and have them function together so that you have what's provided by Medicare, but Medicaid allows you to pay fewer of the costs. Let's see. Jacqueline is asking, is Medicare, Medicaid based on race? That's a fantastic question. So in a formal sense, No, the United States government wouldn't say, oh, we restrict who can receive this based on race. In lots of under-acknowledged ways, yes, race can determine a number of things about your eligibility, either because they're affecting how or where you're eligible to work, or because they're affecting your access to information, or because of some nuances that are essentially built into eligibility criteria. So yes, there is an existing problem and critique of restrictions on access to publicly funded healthcare being racially disparate. We see that pattern based on race and class. So terrific questions. I want to introduce one of our wonderful research assistants and interns today. We're joined today by Siri Patluri, who is working with Repair this spring and summer, and she's going to take over Civics Trivia for today. She prepared today's questions. So welcome, Siri. Let me give you permission to unmute in Zoom. And I'm going to share screen so that our Zoom recipients can see our trivia questions, but Siri will also read each one out for our listening audience. So take it away, Siri.
Awesome. Hi, I'm Siri. And our first question for the Civics Trivia is, what proportion of children in the U.S. are covered by Medicaid? And the options are A, 5%, B, 24%, C, 30%, and D, 40%. So,
and you can tell us now, Siri, what the answer is.
Okay, so the answer for this question is D, 40%. So children make up over 40% of all Medicaid recipients, and that doesn't include those enrolled in the Children's Health Insurance Program, which serves uninsured children and families with incomes that are too high to qualify for Medicaid. And then usually having access to Medicaid as a child can also improve educational achievement, and children who had access to Medicaid demonstrated improved scores in 4th and 8th grade reading compared to those who did not have access at all.
Thank you, Siri.
And so the next question is, what is another name for Medicare? And the answer choices are A, the original Medicare, B, Medigap insurance, C, Medicare Advantage, D, all of the above, and then E, none of the above. And the answer for this question is all of the above. The original Medicare is actually Medicare Parts A and B, and then Medicare Advantage is Medicare Parts C. And then finally, the last question is, how much of your medical expenses will Medicare cover? And the answer choices here are A, 20%, B, 50%, C, 80%, and then D, 100%. And then the answer for this question is actually C, which is 80%, and Medicare doesn't cover dental, vision, or hearing bills. And then I linked some resources for anyone who wants to learn more about like the history of Medicare, more about Medicaid, and like Medicare coverage.
Thank you, Siri, and we'll be sure to include those resources in the chat for those who are joining us live. So last but not least, I'd like to share a book recommendation. The book title is 10 Excellent Reasons for National Healthcare. I've already indicated that I'm a single payer advocate. And this collection, 10 Excellent Reasons for National Healthcare, is edited by Mary O'Brien and Martha Livingston, and it's an edited anthology, as noted. So I encourage folks who'd like to continue to learn about the argument for national healthcare to check out the book. I want to really thank everybody who joined us for today's live session. and invite folks to join us next week to hear our special guest interviewee, Mona Tao from the Equal Justice Society, who will be talking about the intent doctrine, an important area of and problem in anti-discrimination law in the United States. In addition, we'll be back on Sunday, the 25th of April at our usual time, 2 o'clock Pacific time, 5 o'clock Eastern, to learn more about campaign finance. And we will have our monthly film screening on, which is always the last Wednesday of each month at 4 o'clock Pacific, 7 o'clock Eastern time. And our film screening for this month is The Great White Hoax, Donald Trump and the Racial and Class Politics of America, or the Politics of Race and Class in America. And so I hope many of you will join us for that as well. I'll be sure to put the registration and link in the chat. And for those of you listening to the audio podcast, you'll see it in the notes and information associated with this episode. And we're excited to get moving in May and are going to be joined on May 2nd by Professor Kim Hai Pearson, who we're going to be talking to about children's rights and child welfare, and are still finalizing the schedule for the rest of May, but definitely will be doing more on the incarceration of youth and on Veterans Affairs, and we'll also likely be talking next month about disability rights. So I hope many of you will join us in future and also check out some of the other upcoming programs from Repair this month. And we'll end the recording now, but our Zoom audience is welcome to hang out if you have additional questions. Thanks so much, everyone.